Hi, this is Dr. Akhtarami and today's the topic is corneal degenerations. The first one is age-related degeneration. In age-related degeneration, the first one is arcus senalis. Arcus senalis is also known as gerontoxin and arcus lipoides. Arcus lipoides. It is the most common peripheral corneal opacity. Frequently occurs without any predisposing systemic condition in elderly individuals, but may be associated with dyslipidemia in younger patients. In that case, in younger patients, it is called arcus juvenalis. Signs: there is stromal lipid deposition, initially in the superior and inferior perilimbal cornea. It progresses circumferentially to form a band about 1 millimeter wide. Here you can see. The band is usually wider in the vertical than the horizontal meridian. The central border is diffuse and the peripheral edge is sharp and separated from the limbus by a clear zone that may undergo mild thinning. Second type of age-related degeneration is overt limbal girdle. Overt limbal girdle is an innocuous condition present in up to 60% of individuals over 40 years of age, more commonly in women. It consists of whitish crescentic limbal bands. Composed of chalk-like flecks, center at 9 and 3 o'clock, more often nasally. There may be irregular central extension. Type 1 may be a variant of bent keratopathy, featuring a Swiss cheese hole pattern and a clear area separating the lesion from the scleral margin. This is overt limbal girdle type 1. Here you can see Swiss cheese hole pattern, clear area separating the lesion from the scleral margin. The type 2 is more prevalent, distinguished by the absence of holes, typically also juxtalimbal clear zone. Histologically, the changes in both are similar to pinguicula and pterygium. This is type 2. There are no holes. Another type is cornea farinata, visually insignificant condition. Bilateral, minute, floor-like deposits in the deep stroma, most prominent centrally. Crocodile shagreen. Crocodile shagreen is characterized by asymptomatic grayish-white polygonal stromal opacities separated by relatively clear spaces. Here you can see it looks like crocodile. The opacities most frequently involve the anterior two-thirds of the stroma. It is known as anterior crocodile shagreen, although on occasion they may be found more posteriorly, called posterior crocodile shagreen. It may be indistinguishable from Francke's central cloudy dystrophy. Conventionally, the distinction is on the basis of Francke's dystrophy being inherited, but this has been questioned. Lipid keratopathy. It may be primary, secondary. Primary lipid keratopathy is rare, occurs apparently spontaneously, characterized by white or yellowish, often with a crystalline element, stromal deposits consisting of cholesterol, fats, phospholipids, not associated with vascularization. Secondary lipid keratopathy, much more common, associated with previous ocular injury or disease that has resulted in corneal vascularization. Most common causes are herpes simplex and herpes zoster keratitis. Treatment primarily aimed at medical control of the underlying inflammatory disease. Other options: photocoagulation, needle cautery. Needle cautery is suture needle grasped with cautery forceps. The needle cautery of feeder vessels. Penetrating keratoplasty may be required in advanced but quiescent disease, though vascularization, thinning, reduced sensation may affect the outcome. Band keratopathy consists of the age-related deposition of calcium salts in the Bowman layer. Calcium salts in the Bowman layer in the epithelial basement membrane and anterior stroma. There are a lot of causes divided into ocular, age-related, metabolic, and hereditary. The ocular causes are chronic anterior uveitis, particularly in children with juvenile idiopathic arthritis. Other ocular causes are glaucoma, phthisis bulbi, silicone oil in the anterior chamber, chronic corneal edema, and severe chronic keratitis. Age-related causes: age-related affecting otherwise healthy individuals. Metabolic, also known as metastatic calcification, secondary to hypercalcemia, is uncommon and includes causes like hyperparathyroidism, vitamin D toxicity, milk alkali syndrome, sarcoidosis, end-stage renal disease, Paget disease, multiple myeloma. Hyperuricemia is a rare cause. Hereditary causes include familial cases and ichthyosis. Signs: there is peripheral interpalpebral calcification with clear cornea separating peripheral margins of the band from the limbus. Gradual central spread to form a band-like chalky plaque containing transparent small holes and occasionally clefts. Advanced lesion may become nodular and elevated with considerable discomfort due to epithelial breakdown. Treatment is indicated if vision is threatened or if the eye is uncomfortable. It is important to recognize and treat any underlying condition. First treatment is chelation. Chelation is simple and effective for relatively mild cases, performed using a microscope. The corneal epithelium overlying the opacity and a solid layer of calcification are first scraped off with forceps and a scalpel blade, number 15. The cornea is then rubbed with a cotton tip applicator dipped in a solution of ethylamine diamine tetraacetic acid EDTA 1.5 to 3% until all the calcium has been removed. Adequate time 15 to 20 minutes must be allowed for chelation to occur. More than one session may be necessary. Reepithelialization can take many days. Other modalities of treatment are diamond blur, excimer laser keratectomy, and lamellar keratoplasty. Next is spheroidal degeneration, also known as Labrador keratopathy. Labrador is in Canada. Also known as climatic droplet keratopathy. Typically occurs in men whose working lives are spent outdoors. Ultraviolet exposure is likely to be an etiological factor. Condition is relatively innocuous, but visual impairment may occur. A secondary form can follow inflammation or injury. Histology: there is irregular proteinaceous deposits in the anterior stroma that replace the Bowman layer. Signs: there is amber-colored granules in the superficial stroma of the peripheral interpalpebral cornea, increasing opacification, coalescence, and central spread. Advanced lesions commonly protrude above the corneal surface, and the surrounding stroma is often hazy. The conjunctiva may be involved. Treatment: protection against ultraviolet damage with sunglasses, superficial keratectomy, lamellar keratoplasty in a minority. Salzmann nodular degeneration consists of nodules of hyaline tissue, usually located anterior to the Bowman layer. It can occur in any form of chronic corneal irritation or inflammation such as trachoma. Dry eye, chronic blepharitis, chronic allergic keratoconjunctivitis. Signs: superficial stromal opacity, progressing to elevated whitish or blue-gray nodular lesions that may be round or elongated. The base of a nodule may be associated with pannus and epithelial iron deposition. Treatment consists of mainly of lubrication together with control of the cause, removal via manual superficial keratectomy. The lesion can often be peeled away in the supersurface, flattened with a diamond burr. Adjunctive mitomycin C applied for 10 seconds with a sponge may reduce the recurrence rate, though some authorities restrict its use to re-operation. Excimer laser phototherapeutic keratectomy or lamellar keratoplasty are occasionally required. Thank you so much.